Hello, my name's Alasdair MacLullich and I'm a geriatrician working in Edinburgh in Scotland, and this is a very brief guide to detecting delirium in clinical practice. I'd just like to refer you to the website at the bottom there, the 4et.com/delirium guide. This has a brief guide to definition of delirium and ongoing treatment, which I won't be covering in this brief video. First thing I'd like to say is that it's very important that we don't miss delirium. Many people with delirium are very distressed and feel isolated and lacking any kind of support. So to overcome this, we really need to detect it, because this then leads to a treatment plan that can very often relieve that person's distress as well as their family's distress. So it really is so important that we detect it. It's well known that if you don't use a tool to try and detect delirium, that the detection rates are usually very low. This has been shown in many different studies. But with 60 different tools available and with a bewildering array of different validation studies in different settings, how do we solve the problem of detecting delirium at the front door, where most delirium is actually present, versus detecting delirium that arises after admission? And I think there is a little bit of confusion with sometimes people using the same tool for both jobs. And I don't think that works all that well, because the kind of tool that you need for front door assessment, which gives you a good balance of sensitivity and specificity to give you a more definitive answer, takes a bit too long to be done repetitively in the inpatient setting. So how should we handle this particular issue? I think it's quite useful to divide delirium tools into two broad categories. That is, delirium tools that we use in clinical practice. The first is what I'd call episodic tools, and these are ones with, as I say, a good balance of sensitivity and specificity, that when you do them, you have a pretty good idea of the answer without having to do another tool. And these kinds of tools are suitable for use at the front door, where you want a quick answer, delirium yes or no, and also at other parts of the patient journey where there is a high risk of delirium, such as post-operatively, or really at any other time when you're suspecting delirium. And the two main tools that are used as episodic tools are the 4ET and the CAM, including its multiple different variants. There are some one-off tests that have been tested that aren't suitable for ongoing multiple use, such as the UB2 months backwards, which are simple cognitive tests, or other kinds of tests which give an indication of possible delirium, but these are not specific. They're sensitive but not specific. So once you get a score in one of these tests, you need to proceed to doing a more detailed episodic test like the 4ET. By contrast, we have this other kind of test called monitoring tests, and these are done repetitively, usually between 1 and 3 times a day on wards where there's a high risk of delirium. And because of the amount of work involved in doing episodic tests, they're not really suitable for this purpose. Monitoring tests, by contrast, have to be really short, and I'm talking a few seconds, and generally observational, so they don't involve much in the way of interaction with the patient, or if there is interaction, very brief interaction. And some of the tools that are in the literature as monitoring tools are listed there. The SQUID stands for the single question delirium. That's often done once or twice a day, and that just is a single question saying, is this patient different from their baseline? And the other tests are shown there. The CAM is used as a monitoring tool, but not in the way that it was originally written, so with no cognitive test or interview. And unfortunately, it doesn't work very well in that setting, with several large studies showing it has low sensitivity when it's not done in the way that it was intended with a preceding cognitive test and interview. So just a couple of words on the 4ET. This is an episodic tool, as I've said. It takes around 2 minutes, and it starts with level of alertness, because many patients with delirium are sleepy and unable to speak. So rather than starting with cognitive testing, which may not be possible in some patients, it starts with this level of alertness. And anyone who's obviously drowsy or agitated gets a score of 4, which takes you straight to a likely delirium diagnosis. The 4AT also has some cognitive testing built in, which means you don't need to do a different cognitive test if you want to screen for cognitive impairment like dementia at the front door. And it provides several routes to positive scores. So we know that at the front door, many patients do not have an informant with them. And of course, it's extremely useful to have somebody who knows the patient to tell you about their baseline state. But what do you do if you have somebody who appears to have delirium, but there is no informant available? And that's the case in around a quarter or even a third of cases in some studies. So the 4AT allows you to make a judgment as to whether the patient may have delirium based on other parts of the tool, or if you feel that the patient has obviously changed from their baseline, such as if they are sleepy and unable to communicate, and you know from the background notes that they normally live independently at home. Clearly there's a difference there, so you use a judgment and then give a score of 4, which yields a positive 4AT. 4AT is actually now the tool with the largest evidence base, with 24 studies and more than 5,000 patients involved, and several studies now show good real-world performance. Once the patient has a diagnosis of delirium, once you're sure they have delirium, I think it's important not to stop just at that point, but also to assess the patient further to determine what their delirium is actually like, because this then guides your treatment, especially the presence of distress and psychotic features. And I notice in clinical practice that often people say the patient has delirium, but they don't specify whether they're distressed or whether they have these other features. So do go further than just stating that the patient has delirium and document these other features, because this will then guide your approach to treatment. So in conclusion, as I said before, we do need to use tools for reliable detection of delirium, but I think it's important to distinguish between episodic tools and monitoring tools, because they have different features and characteristics and they're used in different ways in real-world practice. We need a robust process at the front door to detect delirium reliably, and we need a separate process to repetitively monitor for new delirium in patients who are high risk after admission, but without placing too much burden on staff and patients by, for example, doing cognitive tests 3 times a day for weeks on end. It just doesn't work. I think it's also important to check whether the tools that you've implemented are working, and 2 good ways of checking this are, do you have good completion rates, and also do your positive score rates match what you expect to see in the population. So if your tool is only picking up 2 or 3% positive scores in a population that's got a known delirium rate of about 15%, then the tool isn't working. And after detection, don't just stop, but assess for individual features such as distress and psychosis, so as to influence your treatment plan for that patient. So I wish you a good World Delirium Awareness Day, and please follow iDelirium Aware to get more information about this, and also I'll be tweeting a lot on the day itself. Thank you very much.